Are we recording?
Just thinking. Yes, started.
Thank you. So, welcome everybody to the governing body and public of Northamptonshire CCG. It's very, very nice to see everybody here. It is lovely to be here in person, and we also have some people joining us remotely as well. If we could have some our apologies, please. Helen, have we got apologies?
Angela Dempsey, Darren Seeger and Amal Gowrie.
Okay, thank you. Do we have an on-call director this afternoon? No? Fantastic.
We do, but not in this room.
Not in the room at the moment. We do have a director on call, they're just not present in the room at the moment. Are there any declarations of interest relating to items on the agenda? Anybody, anything they want to mention at this point? Okay, thank you. So I'm going to go through the minutes from the previous meeting. So that was the meeting that was held on the 21st of December. I'm going to go through for accuracy to start with, and then obviously for any matters arising. Throughout this meeting, I'm going to use the pages on the pack rather than the individual papers. So if we start with page 4, 5, 6, 7, page 8, 9, 10, 11 and page 12. Is everybody happy that that was a true and accurate representation of the meeting that took place last time?
Yes.
Yep, thank you. So looking at matters arising, I think there was only one which is on the agenda. So there are no other matters arising that I'm aware of unless anyone can see any that I can't. Okay, thank you. So we're going to move on with the item on the agenda, item 5. So that's the Chair and Chief Exec's report. I'm going to take that as read and particularly thank everybody that's been involved at this point and particularly governing body members who have got us to this stage. We appreciate that this is a really difficult time for everybody in all sorts of different ways. Are there any matters, Toby, that you would like to particularly draw our attention to in the report?
No, happy to take the report, Joe, and comment any questions. Conscious we have a full agenda today.
Indeed, thank you. Any questions, queries or comments on the report? No. Okay, thank you. So on this occasion, we do not have any questions from members of the general public. We are still really happy to have questions submitted in advance via our website, and obviously those should be matters relating to items on the agenda, and happy to receive those in future. Next item on the agenda is item 8, and that is the Transition Programme Office Report. Over to you, Eileen. Obviously, we've read the report. Tell us what we need to know.
Thank you, Chair. So essentially, it feels like ages since this report went in, actually, and not a great deal has changed in that time, other than just to make sure that everybody's aware that the transition date now is the 1st of July. There's a little bit of chatter about whether that will move again, but at the moment that's the fixed date that we're working towards, and everything is in that respect. Everything in terms of the readiness to operate statement and what have you, we have extra submissions to go in February and mostly in March. The PMO continues, although everybody's had COVID over the last couple of weeks, so small team, lots of COVID. But we continue to work through the work streams, but also working with Ali and colleagues around the collaboratives. I think where we are now focusing a lot of our attention is around shadow board arrangements and what things will look like in the future in terms of membership, and Neil's been very involved with that. So work continues. We've got a little bit of extra time, which will help us in terms of some of our stakeholder engagement plans and communications in particular, for which we will probably right up against the wire in terms of our ability to communicate what it is we're trying to do and also get feedback from our public. So nothing startling from the last time we spoke. I don't think there is an inherent risk around dates changing, and if that happened again, then we would have to sort of work out how we do things in the meantime between now and the transition date. And I don't know if Sarah wants to talk about, obviously there's a boundary change issue, and just to make everybody aware that the notification has now come through that the boundary change will happen at the same time as the ICB standing up. So that puts that back a couple of months as well, which is problematic for all sorts of reasons. Looking on the positive side, it might give us a little bit more time in terms of engagement with Outdoor and all of its component parts. So that's the big news, I think, from the last time.
Thank you. So was there anything you wanted to mention about the boundary?
I think Eileen's picked it up really. We've now had confirmation that it will be the 1st of July, the same as the date for ICB establishment. And also confirmation therefore that if the establishment date moves, so will the proposed date for boundary change. So they're now, from a guidance point of view, tied together. I would just say that there were a number of risks with us not knowing. There are now a number of crystallised risks with us knowing, which particularly from a finance point of view means that a part year change is much more challenging to mobilise. Stuart's joining the national group to work through how we might do some of that and the requirements therefore. But it's good, it's useful for clarity, although I probably would say that it isn't ideal in terms of some of the processes that we now then need to mobilise, but we'll work through those with support of regional and national colleagues.
Thank you. Anybody got any questions for Eileen or Sarah?
Philip as well. Mine was two comments, if I may. The first, just picking on the boundary piece, the obvious other issue it presents is in terms of the rationale for that boundary change in the first place, which particularly from a local authority and political perspective is very much supported from the North Unitary. We are obviously having to need to manage that kind of interface as we go through the next few months. The point I wanted to make was really to acknowledge the change process we're describing here is, difficult and challenging, and I know that for various people around this table that's impacting personally as we go through this kind of period of change. I just want to put on record my thanks to all of the people around the table in lots of different roles, many of whom are in quite uncertain positions at the moment, personally, career-wise. Both what people have done to get us to where we are today, but also what people are carrying on doing in spite of that uncertainty that some folk are working under as well. I think that the dignity and professionalism that people are showing in that regard is appreciated, and I wanted to acknowledge that. The other piece to obviously note, Chair, is that we've got a session appropriately in our second part of session where we're going to get into more depth around transition, shadow operating, what those timelines mean for us as a governing body and as an organisation. And I think that's a place to get to some of that conversation in more detail. So I'll hold those thoughts for later.
Thank you. Philip.
So it's around the part around communications and engagement, where it talked about the community being embedded within the ICS. I see it as potentially a two-way issue, which I think we need to address really as a matter of some urgency. Certainly I've got members of the community who are asking me what's happening about community involvement and how can we get involved in the development of services. And we've had a 2-year hiatus where the primary care team organised the locality meetings and the individual practices fed in through their practice participation groups. And we seem to have lost all of that. And I think it's not just an embedding in, it's also going back into the community for their involvement in sharing. And I was a bit concerned when I said we will work in the coming months to aim to have a strategic approach. It all seemed a bit slow to me.
Thank you.
I think so. I would disagree with that, and I think, as I said, I think we're behind the curve. So although I refer to the next coming months, obviously there'll be a process that continues afterwards. I think from a comms perspective, we do acknowledge that it's not where it could have been, and so therefore we've got a lot of ground to make up and make sure that we do whatever we do well, as opposed to paying lip service to here's a strategy, this is what we're going to do. So Dion and the team and some external support will be getting into the detail around that. So we will be able to go out and make sure that there is more involvement. But I think we're behind.
Yeah, and certainly, personally, it's something we're very keen to get involved and support with and re-establish a lot of what happened before. So,
thank you. Will.
Yeah, thanks, Joe and all. And could I just do two things really? One, to reiterate Toby's thanks to everybody for keeping nose to the grindstone during a very difficult time. And so thank you for what you've done, and thank you for everything that still can be done, I'm sure. Just on this particular point, the comms and engagement, it's an offer really. As you know, I'm only the interim chair of HealthWatch, but we've got a HealthWatch and we're looking for a new chair to replace me as soon as possible. But we've got HealthWatch board coming up next week, I think it is. And it's an offer really. If there's anything that HealthWatch can do to help on that comms and engagement, the public engagement piece, please do ask, and I'm very happy to to table the, if you like, the need for increased comms and engagement at the meeting, if that would help.
Thank you. I'll definitely contact you outside of the meeting.
Thank you, Will. That's much appreciated, and for all the engagement that that HealthWatch does. It is really important to hear the voice of our public as we care for them. So thank you for that. Any other questions, queries, or comments? Okay, thank you. So thank you, Eileen, much appreciated. And as we've said before, the CCG continues to need to maintain all of our statutory duties until the ICB is in place, and mindful that we will continue to do that. And our thanks really to everybody who is helping that to happen. So thank you. I've also been very remiss at the beginning of not formally welcoming Matt as our local medical director to add additional clinical voice today, who is in attendance, and you are extremely welcome. So thank you for joining us this afternoon, much appreciated.
Thank you, it's lovely to be here.
And you are allowed to speak at any point, but please put your hand up first. Next item on the agenda is number 9, which is the outcomes framework. So this is much anticipated, heralded from previous meeting. Obviously we have read it, Lucy. Tell us what we need to know.
Thank you, Chair. So I'll take the paper as read, but this is something that we've obviously taken to various boards previously from a point of view of sharing the methodology. We, for all intents and purposes, pulled together lots of routinely reported data to identify where we don't perform as well as we would want to, or compared to peers, or indeed identified opportunities for better sort of financial or clinical outcomes. So we've created a long list, and as people will have seen through the slides, we've then gone through a process of creating a prioritisation framework and engaged with partners around which priorities should be given which weighting. Interestingly and quite appropriately, inequalities and addressing inequalities is given the greatest weighting from a point of view of us being able to prioritise a programme of work next year. And we've now brought this down to a sort of refined set of outcomes for the first year of the ICB, focusing each sort of component part of the life course on 3 to 4 outcomes to achieve. Now, recognising there'll be lots more work happening in the system, but this is about people getting behind 3 or 4 particularly pertinent issues locally or challenges locally, and making sure that we're working in partnership to address them, so sort of really testing that integrated part of the Integrated Care Board. So this is a reminder of the methodology and the fact that we have now got to a sort of a short list of items. What we have included is, you can see the sort of rankings of each of the collaborative areas. So lots of people obviously will have questions about where certain priority areas are in the next couple of years, because obviously almost everything will be a focus for the first year. So including those outputs by the different collaboratives means that you can sort of see what's likely to rise to the top in the forthcoming years when this is refreshed on an annual basis. But towards the end, so in our pack, page 43 shows you the issues and challenges that have risen to the top for the first year. And our next step is to take this to all of the organisational boards and back round to the collaborative strategic boards, for them to sort of look at whether they feel that these are the most appropriate and pertinent areas for them to be focusing on in the forthcoming year, and to identify where we may have any gaps in our data, particularly around some of the qualitatively collected issues and priorities that they may engage with service users on, which, as I said, from a quantitative numerical perspective, we won't have necessarily captured. So we'll take that to the boards and obviously look at refining it based on some feedback and bring back what we would hope at that point would then be the final version. But the other thing we're just asking for is feedback on the methodology. Obviously, it's been an ongoing and iterative process, and I'm sure we won't have got it right yet still. But looking forward, obviously, this will help us identify our strategic plans year on year. And as I said, help us focus our resources, both financially and from a staffing perspective. So it's important that we get this right. But happy to take any feedback and or any comments on next steps.
Thank you, Lucy. Much appreciated. And I appreciate this has been very much a labour of love and a difficult journey to get here, and everybody wants to do everything, but by necessity there will be some areas that we need to focus on, and it's important that we are logical with those areas and how we choose them. Any questions or comments? Annie?
If you take the exec boards of the 4 emerging collaboratives and the engagement, it's been a real education for them, I think, to understand the difference between outcomes, outputs, transformation. So what Lucy's describing is actually educating the system as well as making sure we're clear on our outcomes, and they are varied in their understanding of that, aren't they, as they mature through. So it sort of leads into the cases for change that we're about to talk about in the agenda, but I think it's important to acknowledge that. So it's been really helpful and insightful, I think, as well.
Thank you. Brilliant.
Yes, can I say first of all, Lucy, how sorry I think we all are that you'll be leaving us. To thank you for the tremendous, you completely changed public health in this county in the time you've been here. It's been absolutely fantastic. And from what was a devastated team, you know, when you took over, it's, you know, I'm sure everybody's absolutely leaving. When I looked at this, it came across as something we've been needing from a point of view of the locality board, which I chair, who are looking into their function with a view to becoming a collaborative primary care combined with NHFT provider organisation. And I just wondered what your thoughts were around sharing this so that the GPs are also part of this vision in terms of what we're going to deliver from a community perspective.
So
it's the first time I've seen this.
Yes.
I've, you know, for me to see it, it's fantastic. But I think we need to begin to communicate, you know, with the people who are delivering what the vision is for the future.
So primary care is on our list of places to visit. I think our challenge is you all hold your locality boards at the same time. So we're working out how we can make sure that we've got people who are sort of distributors who can go through the methodology and get that feedback from you, but also working with the LMC as well to make sure that, again, they've got oversight and can communicate any changes that may need to come that direction. But no, we do recognise it's one of the things that we need to, I don't particularly like the word, but better socialise. But the bit that I think is part of our challenge is, obviously we've taken a life course approach on this, but it does sort of dock into the collaboratives quite nicely. One of the things that I think we'll need to look at it again through a lens of place, like some of the ICP arrangements were a little bit clearer, and I think some of the collaborative ambitions that you've just articulated will be very place-based as well. So thinking about how we can make sure that it still works in that context, as opposed to a pure sort of life course or clinical pathway approach. So I think that's one of the things that we need to reflect on over time to make sure that it's still applicable in that setting.
And we can help you with the logistics of the locality meetings. There is a virtual magic carpet that allows you to attend all 4 on a single day.
Wow.
So these things are entirely possible, and it has been done by various people around this table, so you can do it. It's hard work, but you can do it. So thank you. Andrew.
Right. It was just a question around the long-term impact and how the measurement of that long-term impact will be weighted, because obviously there's going to be some ambiguity around those measures versus the short-term impacts of in-year activity or in first 2 years activity, and how we sort of, how's that going to work to ensure we don't have a short-term view?
So it's a really good challenge. It's one of the things that Nisha and I have been putting our heads together on. So underneath each outcome, there will be a logic model, and there's sort of some examples given of what would be included in that. And as Joe's alluded to as well, it also sort of breaks down very specifically what the outcome is that you're trying to achieve. And over time, the outputs that you would expect that would demonstrate progress, some of those will be quite short and sharp. Others, as you quite rightly say, particularly when we start to consider the levelling up agenda and some of the root causes of some of these challenges, will be very much long term. So as we go through the annual refresh, one of the things that we'll have to develop in the background is a kind of a summary of the ongoing progress against medium and long term outcomes versus the refresh that will generate things that will again add to those lists, but also identify those short term outcomes. So some we should expect to close within a year. Others, as you say, will end up being additive to a much longer programme of work. And that's the bit that we need to be really careful of, is 4 or 5 years down the line, we haven't still got a list that's now 20 outcomes long, because our focus each year is taken onto the new things and we forget to continue to work on those medium and long term outcomes. So there is a kind of a very strategic view that's needed whilst you retain an operational grip on delivery.
I think
that makes sense.
Yep, absolutely. Naomi and then Teddy.
Thank you. I just want to make a couple of points. One is it is a phenomenal piece of work and it's very, very difficult work. It's very important, and I'm really delighted to see how much outcomes framework features in the integration white paper that's just come out. So it's not just us saying, you know, this is an important thing to do for our system. It is the centre saying we have to do this and we have to do it right. And the other thing that I was pleased in terms of the integration white paper is that a lot of the discussions that we've been having about the integrated care board and governance, where we will be bringing local government into the governance of our system, is how do we ensure that different component organizations aren't arguing from their organization point of view, they're arguing for the key aims of reducing health inequalities, improving health for all. That's what the outcomes framework will be used for. The argument will be, you agree that this is what we're trying to achieve for our population. Explain why the way you're approaching this problem will help us achieve that, not this is good for my organization. And that means that it's critically important that, as Lucy says, that it is iterative, that we review it each year, but also that all the partners, including local government, including acute, sign up to this as, yes, we agree, these are the things that really will shift the dial on health for all and health inequalities. So I don't think that we're there yet, and there isn't going to be a sort of perfect one, but the absolute commitment of the key partners to it will help ensure that the ICB achieves what it's meant to achieve. And that's why I'm, you know, really pleased to see it, but think that we really need more work.
Thank you. Toby.
Yeah, thank you. So just three quick comments from me. The first, I was going to make the link that Naomi just has to last week's integration health and care white paper. If anybody's not read it, it's not a long document, it's well worth a look through. And I was really pleased to see section 2 on that is all about shared outcomes and the importance of that, both from a place point of view and from an IC integrated care partnership point of view. And I think just further reinforces the need for this work. The other thing that reinforced in my mind was the importance of making sure that this work in socialising phase that you described, it genuinely has the opportunity for partners to feed in and to react to this, because to work and to do what Naomi just described, for us to get behind it that way, it really needs to resonate and speak to the things that people think need to be addressed for our population and for our patients and staff across the system. So I would really encourage anyone around this table, whether it's Philip the localities or any other partner organisations we work with, to make sure people look at this and give it some considered thought and feed views back in. There is no perfect single version of this. We all know that. There's an element of science, but there's also an element of kind of policy judgment all effectively with some of these things. But whatever we settle on as a system, it has to be something we can all look at and go, yeah, that's speaking to the right things. We can get behind that. We can do the kind of approach that Amy described in terms of how we operate going forward. So I really welcome it. And I would just add to Philip's personal remarks to Lucy, I think this is probably end up being your last governing body meeting with us from the CCG. I'm just doing the dates in my head and thinking when you head off elsewhere. I'm sure Joe may want to say some things in a moment, but I just want to put on record my thanks to you and the team for getting this to where it is, because it's moved an awful long way over a number of many months of work alongside everything else that public health teams in particular have been grappling with. So I think if we can get this to a finalised place, that will be a good legacy amongst many other things.
Yes, I kind of put the slides into two sections, because the other is the health inequalities plan, which is a requirement for every ICB to have one. The draft is required in March, and it has to be led by the Director of Public Health, or directors, as it will be. So North and West now have appointed 2 interim directors, and one of my team in the council is currently leading on the development of the health inequalities plan alongside a number of CCG colleagues. And that obviously looks through an inequalities lens much more broadly, and I think will help, as Naomi said, make sure that we as a system are addressing the underlying issues. So the outcomes framework is a sort of a snapshot of things that we particularly want to focus on. The health inequalities plan as an ICB will make sure that we obviously have a strategic approach to addressing those causes of the causes over a much longer period of time. So I just want to make sure that people are cited on that requirement, and we will bring that draft back in March for you to again comment on as governing body.
And perhaps the only slight bonus of COVID is the fact that people are actually now talking about health inequalities.
They are indeed.
And I think this has been the first time that that has become a normal topic of conversation in the media, and absolutely welcome that. Yeah, absolutely build on everybody else's comments, and thank you. In particular, obviously your team have been very much involved with this, but we will miss you. It has been wonderful having you part of our governing body, and everything that you've done over the last couple of years in particular. It has been a hell of a ride, I think is probably the phrase. So thank you both. I know you've got another item later on in the agenda. And just to make one final comment on this item, obviously these are the outcomes that matter to our population. They're the things that really matter. But I don't think any of us should think for 1 second that these are the only things that we will be performance managed on as a system. And there will be a number of other arbitrary measures which unfortunately may increase in number, not all of which produce meaningful outcomes, and we just need to be mindful about balancing the multiple demands on our system versus what actually matters to our population, which is much more likely to be these areas. Thank you. So I'm going to move on to the next item on the agenda, which is item 10, which are the collaborative cases for change. So if we could start with the one for mental health. Ali, I believe you're going to start that one. And if you could just give us some clarity about what we're asking governing body to do as well. Thank you.
Thank you, Chair. If I may, I'm going to just provide a bit of context because there are numerous slides in the deck. So I'm going to take us back a step. So this governing body has had many a discussion about the development of the programmes as they move into collaboratives through our development sessions. They are an integral part of our integrated care system operating model, so we need to make sure they're right, and they are important in the delivery of the outcomes that Lucy's just been describing, the outcomes framework. So there are two cases for change. You've got the mental health case for change and the elective care case for change. And it's just to note that the ICANN and the children and young people's cases for changes will be coming to future governing bodies and through the partnership in the ICB, but they're not in the position that elective and mental health are, but they are progressing at pace, so it is important to note that. So the cases for change are describing the problem that we are trying to fix for our population and why and what the solutions are, and there are exact summaries in your deck for that. And there are two asks really, so they're there for assurance in terms of visibility for the governing body. They have been through numerous lenses of governance between chief execs, CCG execs, partnership board and the central collaborative work stream. And probably also to note, this has not been an easy journey through the development of these cases for change, and has been real credit to system working and collaborative working, which is a great foundation for our ICS. So the final point that I'd like to make is the mental health case for change has a specific ask of governing body in terms of just continuing and support and approval for continuation of the work to build the contract for the outcomes-based contract for the 1st of April and to implement it on the 1st of April for adults and older people. And also the governing body to note it is the first part, is the first phase, the first tranche of the whole programme. It is not the entirety of the programme. So I just thought that context would help, Chair, but I'll take the rest of the deck as read. I'll just turn to Sarah to see if she wants to add anything in relation to the contract, and happy to take any questions.
Thank you. So any questions about the mental health aspect? Chris?
Hi, mine's only a presentational aspect more than anything else.
Okay.
It does mention on the script about what the performance were 2019, with associated pictures of people huddled round tables, etc. But given it's coming out outside of the COVID pandemic,
yes.
I wonder whether we need to emphasise that those photos were taken pre-pandemic.
Okay, I wasn't expecting that question, Chris, I have to say, but I take on board your point. So I would say, well, take on board your point, but probably our focus has been on other components of the cases, the case for change, and actually being clear that everybody understands the problem, but take that on board. I would also say these are not for the public domain currently. They were for the purpose of the partnership board and for boards, and we will be making sure we do the right communication. But we do need to get our message in, our language and our vision visibility.
Yeah, it's just if it's going into the public domain. So.
Yeah, so they're not at the moment, but yeah, thank you. Any other comments? Okay.
Sarah. Did you want to comment?
Yeah, I suppose just to add in terms of, so the recommendation for the mental health case for change is to continue development of the outcomes-based contract for proposed signature on the 1st of April. Just really to update colleagues, there is now a final draft of that contract, which is with functional and subject matter expert leads for review across both this organisation, NHFT, and other parts and other relevant parts of the collaborative. And we will be proposing to bring that through governing body for its final approval next month, just in terms of timeline and expectation. As Ali says, that will be for tranche 1 of the proposed collaborative contract, but we'll outline that in much more detail for the paper you see next month.
Okay, thank you. Philip?
I mean, as a concept, Ali, I'm fully supportive of all the work that's gone on. I think when I read the paper, what I couldn't see is how those patients that I refer to services with extremely long waiting times, like adult ADHD, autism, IAD services, personality disorder services, how that's actually going to be improved, their access by these changes. And when I looked at the outcome measures, they seemed to me, a lot of them were processes rather than outcomes. And when you looked at the outcome measures that were actually in the paper, they seemed very soft in terms of waiting times for patients to be seen, and deliberately set to be achievable rather than to be stretching the organisations to improve matters. I don't know what your thoughts were about that.
So there's been many a conversation, Philip, in the programmes and the collaboratives about this. So the access and the waiting times are a consequence of other things not being right. So they're a symptom of it, but they're not an outcome, as you describe. The outcomes for the patients is that they remain healthy and they shouldn't have to wait and they have access when they need. That should be where we're taking the direction of the programme. So the intention for all our programmes, because we've got waiting lists across all of those programmes, it's not just the mental health and case of change, as children as well. The intention is, hence the elective care focusing on its waiting list. So we need to sort that out. So it should be, are you saying it's not coming out clearly in the cases for change, but that is part of the intention for us to address that?
It didn't come across clearly for me what the improvement would be for those patients. Maybe I didn't read it right, but I couldn't clearly see it.
That is part of the intention, obviously, and that's not right across the board in Northamptonshire currently, our waiting lists. And you can see that with the performance report that we've got later in the governing body as well.
I think there is an element of that within the I statements that are there, and I think although I statements are a relatively new thing within our county, that potentially gives the meaning that you've been talking about is what it actually means to those people to feel well cared for and to feel that they're on the right journey. But perhaps we can put a little bit more emphasis when we're talking to the general public.
And also, going back to the point you're making, this is the first step. It's not solving everything in one go. So we need to start somewhere and then move towards some of the really tricky issues as well. So otherwise we're not going to move forward. And this is about wrapping those resources and the contract to do that first tranche that we've described in the paper.
And so there'll be contract review and target review after a year, or how will it work?
So I'll hand that one back to Sarah, but yes, because there'll be a contract linked to this in a different way.
Yeah, so the contract is proposed to be a 5, we'll get into the detail we're going to get into next meeting, but the contract will be proposed to be a 5+ 2 year contract with NHFT as the lead provider and a number of other organisations, particularly from the BCSE sector, sat around the sides of that. There will be parts of that contract reviewed on an annual basis, particularly those measures around finance, efficiency, growth, etc. And there is also a potential in there for, if significant changes are made by our regulators for performance requirements, for them to be built in as well.
It's a different way of working, really, Philip, I think, and also it's about as the collaboratives mature, is the delegated responsibilities that they will have and how much delegation. So this is the start, because it's the contract and resources, and it's that movement towards performance ownership, quality oversight as we progress. That's part of the model. But it's a good start, it's a starting point. It doesn't answer everything.
Thank you.
Yeah, thank you. Slightly picking up on some Philip's point, and also a slightly broader point. The broader bit for me with both of these actually is that I think as a county, we often don't tend to be very good at talking about the stuff we're doing that's reasonably progressive and innovative. And this space, the collaborative work, is very, very much at the front end of what there's a lot of talk actually about collaboratives, and a lot of talk about in conceptually how they might work, what they might look like. This is such a massive part of our Northamptonshire model in terms of what we do over the next few years. In terms of, you think of those people being around this table in CCG years gone by, where we've talked about moving to a more strategic commissioning mode, and some of the more tactical commissioning or the kind of service improvement and redesign and delivery should be kind of owned and taken forward more from a provider point of view. This is doing that. And as you're right, this is a journey bit, this is kind of a step towards all of that. But certainly from the last 12 months, this agenda feels like it's moved on hugely locally, and there'll be all sorts of challenges to work through going forwards. But I think those of us around the table that carry on from July with ICB kind of mode locally, I think this becomes a huge part of our model across the county and something that's really strong to build from. And I'm really pleased that mental health is going to come back in next month to get that bit signed off. The link there to Philip's comment is, I think that it also then really changes the way that the ICB, in contrast to sort of previous commissioning models, needs to operate in terms of holding to account and oversight around delivery. There's a bit of a link back almost to the outcomes framework stuff, because if you look on slide 79 in our roll papers, which is 24 in this pack, there's a section on the mental health one that sets out the kind of 14 collaborative aspirations. We've got to keep coming back as an ICB and through the committees and governance in ICB to, are we actually making the difference we've set out there? Because I'm sure lots of us have sat over many years around tables where we've had documents that have said all the right things, but do we really manage to move it on? I think this, for the first time, has really put a significant resource behind this and empowering particularly providers and operational teams and clinical and professional teams to get on and do the things that make some of this stuff happen. So I guess it's really, I'm excited to see this here. I think it is the ambition we've talked about in terms of strategic commissioning and ICSs, and it is the bit, I think, which has got a huge role to play in how we develop our new model going forward. So,
thank you. Any other comments on the mental health aspect of this item? So what we're being asked to do as a governing body is to approve the progression to the contract for tranche 1.
Continue development of the contract for implementation in the 1st of April. We'll be coming to governing body in March, I think. So,
okay, so is everybody happy to approve that progression at this point? So
just as added assurance, it will go to Finance Committee before it comes here.
Thank you. Thank you. Okay, so I think I've seen almost enough nods. Yep, so that's approved, thank you. So the next item is the elective care, again, the second of the 4 major work streams that we're looking at, and very much in the newspapers at the moment.
Indeed.
So yes, tell us what we need to know.
So the same general narrative applies for the elective care case. I suppose the key message around it, the problem it's trying to solve, goes back to your point, Philip, about waiting lists. So it's not clear how many patients are waiting in the independent sector, in primary care, in the acute sector, in the community. So this is to understand population needs for elective care and having a collaborative oversight, having one patient waiting list effectively. So there are so many problems elective care could focus on as the starting point of the journey, that unanimously this was felt to be the right start to build that single oversight, and then you can start to build in the transformation work, and particularly the out of acute hospital service models. So it prevents that, if I use a Jonathan Cox analogy of the motorway of patients going to the acute hospital. So we're managing them in the right place. And fundamentally, primary care is absolutely at the heart of this. And I should say, particularly for governing body, primary care have been integral to a lot of the development of all the cases for change. So I haven't got anything else to add. Happy to take questions.
Thank you. Any questions on the elective care aspect? Okay.
Thank you. I think one of the problems is that we will be under huge pressure to get people through, and therefore we'll get people through who are the most willing. And it worries me in terms of the reports most recently about inequalities in health outcomes for minority ethnic groups who may not come forward, So I just think we have to be really careful and make sure we have some measurement of protected characteristics as well, so that we're not advantaging the already advantaged. And this is true, yeah, in terms of poverty levels as well. I remember hearing in Milton Keynes years ago that there were fewer hip operations in the poorest areas of the town as in the rich areas, because people who had bothered hips, you know, thought, yeah, I deserve a service. So they said, oh, well, I can live with this. So I think we have to be careful that in our push on elective, we don't wind up widening health inequalities.
So we're pleased to know that's exactly the conversation that's happening within the programme, and health inequalities, and actually the significant problem we have around that currently. And also it's about harm to our patients waiting on our waiting lists and the invisibility. So yes, you're absolutely right. And again, that hasn't been done before really here. So that's particularly with the independent sector.
Thank you. I've got Philip, Lucy and Matt.
I'm just going to ask Ali, the access to diagnostics is key to a lot of the work which we do, and a way of avoiding referral to secondary care and taking pressure off the system. And when I looked at it, the access to diagnostics is being led by the acutes. And I just wondered if there were in that work stream, whether there was any primary care involvement to identify the needs of primary care rather than the needs of the acutes for medical.
So just for a point of accuracy, it's a system group developing the diagnostic pathways, which includes GPs and some of your colleagues. So it is being led by an acute lead, but with a system hat on. And it is absolutely linked into the elective care board. So it's, for example, the community diagnostic hubs. So I think it's been a bit of a painful journey, but that isn't the case. And that I think is probably one of our slowest transformation programmes at the moment, the community diagnostic hubs, but we're trying to grip it and move it at pace. So just for clarity and accuracy, does that help, Philip?
Yeah.
Assurance really more than anything.
That's what I was thinking, yes, that's fine.
Thank you. Lucy.
It was to come back to Naomi actually on some of the comments that she made about seeking assurance around how we make sure that we don't widen inequalities. So one of my public health leads is involved in the elective work stream, as is one of the population health leads.
Yes.
We've also shared some best practice from the strategy unit, who have done some national analysis on how we address some of the inequalities and waiting lists. But I've also been invited to the group board development day in 2 weeks' time, which is focusing very specifically on health inequalities, and I'm doing a kind of a contextual piece, a bit about the outcomes framework, and then we're also talking about the elective programme of work, and obviously very specifically within the acute setting and how we make sure that those elements are considered. So actually some of these discussions are really joined up at the moment, which is really pleasing.
Brilliant, thanks Lucy.
Fantastic. Like I said, we're going to miss you. Matt.
Much of what I was going to say has already been covered by Lucy, but I've just wanted to Naomi's point to acknowledge your concern around the risk of inadvertently increasing inequality. The design feature around a common referral hub and referral management has a number of advantages, not just in terms of managing capacity and coordinating pathways and preventing patients from being ping-ponged back to primary care and in unhelpful workload on surgeries, but also in that we can monitor that we are providing equity of access, learning from the lessons of previous forays into patient choice, which of course was really a choice for affluent and able people. So your point is really well made, and I'd just like to offer reassurance that it is fully considered in the design process. And just on diagnostics management, to Philip's point, I think I completely agree. There is good evidence from other systems that if you involve primary care in the design of your diagnostic pathways, you can actually significantly reduce demand for them as well with a bit of support. So completely endorse the point.
Thank you. So now I've got Toby and then Chris.
Thanks. Just a really specific point. I spoke a few moments ago in general about the collaboratives and the kind of opportunity piece here, but to point to the scale of the challenge as well as what we're trying to do here, page 140 in the pack, which sets out the ambition around the elective side of things. There's a bullet point tucked in there under the acute provision line, which talks about non-specialist elective work on a single site with national exemplar theatre utilisation, single pathways for patients. That's massive potentially. To me, it's absolutely in the spirit of what we backed and supported the group model for the acute services across the county in terms of the two acute sites working together in a much more joint way. But I think it points to the collaborative we're going to have to both grapple and deal with some of the operational kind of waiting list improvement, trajectory issues at the same time as not losing sight on some of the bigger, more strategic agenda stuff here, which in this case starts to take you into the configuration of some of our services across the county and across a number of both those two sites and potentially others going forward. So just to note that huge opportunity here, but some really big territories are going to start taking. And I think as an ICB going forwards, the system needs to be rightly kind of challenging and encouraging other parts to go into that space. That's what we need to from a patient and a workforce point of view. Thanks, Joe.
And just building on that point, mindful that changes to the elective pathways and processes then obviously have the potential to affect the non-elective. And it's also really important that we look at the connectivity between primary and secondary care, but also the elective and the non-elective, because it's important that our patients have robust services. So, like you say, fiendishly difficult, but important to do. Chris?
It's more of a comment based on both Naomi and Lucy's comments. There is, again, to use your analogy of the motorway, there's a whole load of cars not even joined the motorway yet.
Yes, very true.
Whether they are being actively held by the GPs not referring, or whether it's by patients not contacting their GPs. So once you start to unlock your motorway, there may be more cars coming.
Indeed, which is even more of a worry. Exactly. So that completely reflects the.
You're stimulating demand for a free good.
That's before you've got a toll bridge in there, but yes.
But I do want to emphasise you have to start somewhere. We can't, and every time you go into a room, everyone has a different take on what the main problem is, depending where you're sitting in the system, which is why we started where we have the recommendation.
Absolutely. But this is important work, and it's something that causes an enormous amounts of frustration as well as clinical harm to our population. So it is important work, not just because there's a national focus, but because it's actually important to our population as well. And so we can get things a lot better, and we can reduce people's frustration, and we can reduce staff frustration as well alongside that.
And it's just to emphasise, this is a commissioning and a provision change, not just a provision change. So collaboratives are commissioners and providers working together.
Thank you. Any other comments on elective?
Yeah, I spent quite a lot of time reading these papers, and in terms of the analysis, I thought they were excellent. They really did a good job in bringing together a lot of quite complex principles and aims. I think we're probably doing ourselves a slight disservice in terms of not emphasising how innovative and radical and creative some of these elements can be. And to take up on Philip's point, the community diagnostic hub, getting diagnosis and referral out into the community in the hard to reach areas, I think that's quite powerful. And they're so big, the papers, it's very hard to always pick out the pearls within there. So I think if I was writing them again, I'd like to see another page sort of summarising the big changes, the radical differences as we go forward.
Thank you. I'm mindful that we may not be the worst in the Midlands, but then actually our population deserves the very best. And so not to be complacent about our numbers, sometimes not looking as scary as others, it's still really important for our population that we continue to improve. Thank you. So thank you, everybody. A rich and varied discussion. Look forward to the other two work streams coming to governing body as well. And it's really good to see things that are actually going to make a difference for our population moving forward. So thank you. So the next item on the agenda is item 11, which is the planning guidance. This obviously has your name next to it. Sarah, obviously we have the report, we have read the paper. Tell us what we particularly need to know at this point.
The report's for note. I don't have an awful lot to add to the paper other than merely to explain that it summarises the current system approach to the 2023 planning round. It outlines the delivery structure, the structure of submission and what we have to submit as part of this year's planning process, 22-23. And just to add the couple of things that have moved on since the paper was written. So there is now weekly executive oversight of the planning round as well, which is now happening on a weekly basis. Engagement with regional and national colleagues again on a weekly basis as part of developing the submissions. And also probably to add some specific support around elective recovery planning. which is being supported by the elective care board, but is coming to us from NHS EI regional and national teams in terms of some further support around elective recovery. But nothing other than that to add, Chair, so I'm happy to take questions if there are any.
Thank you. Any questions for Sarah about the planning guidance and programme? No?
I'd assumed you didn't want to see all 100 and something pages of the actual planning guidance, so we've tried to summarise it.
At this point, we trust that you have read those and we will distill what we need to know. Thank you. So thank you, everybody. So we're going to move on to the next item, which is the Lucy's last public health report. As ever, absolutely fascinating. Tell us particularly what you'd like to draw our attention to.
Thank you. So there's obviously quite a lot going on, so you'll have to cut me short if I do end up including everything. But it's so nice to start to get back to some business as usual. Obviously, we've been trying to keep things ticking along during the pandemic, but I'm sure you can appreciate quite a lot of my resources has been drawn into managing that, and potentially will continue to be so for some time. But what we obviously have done is summarise some of the changes, and as I've alluded to already, the splitting of my joint post into 2 separate DPH roles has continued. So the North are now at a stage where they're about to interview for the substantive role, and we have Professor John Ashton, who's been in post as an interim now for 6 weeks, has had a very good handover. In the West, they've now appointed an interim DPH, which I think will be announced later this week. And I understand that they'll be going out to advert imminently for the DPH role for the substantive candidate. But there are some other changes included in there, but obviously just want to make sure that we continue our very strong links with the ICB and the CCG in the transition period. One of the things that we've launched recently, as you'll see, is the Well Northants programme. So it is a pot of money basically that will be provided through a grants process and will be coordinated by 6 community development workers. I'm sure most of us around this table have been around long enough to remember community development workers of old and the work that they used to do with grassroots organisations and individuals to build on community assets, and in particular to reach out to those that we've already talked about a little today, who are furthest from our services, who are the least health literate and with the least understanding of how to navigate some of our services and identify who best to seek support from, but to make sure that they obviously are upskilled, they are empowered to identify and address their own issues at a community level. And then there are 2 very specific community development workers who are doing some very dedicated and detailed work with people who are very much sort of on the peripheries of our services. So people like the traveller community, sex workers, our homeless population. So there's sort of general community development workers as well as some very specific targeted work going on. As I said, they'll be able to access a public health grant pot through a process, and we'll be supporting them to build assets locally that help them address some of the local need. But it's a really good example of how we can start to address inequalities and support our communities to address some of the inequalities in the system, and obviously evaluate that, and we can take some of that work programme forward. One of the other things that we've been doing is collating all of the mental wellbeing information services into one place. We've had a lot of requests for additional sort of low-level mental health support following the pandemic. And therefore, what we've tried to do is make sure that we've commissioned the services that are required at this point in time, recognising that, as we've also talked about, there's probably quite a lot of unknown need at this point in time, but also make sure that all of the assets that we've got in the system are understood, and therefore we've created a web page where people can seek the support that they may need in its various forms. There's online platforms as well as things like links to social prescribing and more formal sort of trained interventions. So hopefully that is helpful to people, and you've obviously got a link there as well to make sure that if you are aware of any services that aren't on there, if you could let us know, we can add them on. And lastly, the only other thing I'll draw attention to is the whole system's approach to healthy weight. We've talked about this before here, and we brought a sort of a map around how we were going to start to tackle some of these challenges, which again have been exacerbated by lockdown and everybody being only a few steps away from the treat cupboard, I think, in the last couple of years. So I don't know if people saw stats yesterday, but the most recent childhood measurement programme has demonstrated quite a steep rise in obesity and overweight in young children, and therefore obviously making sure that we take a community approach where we're looking at both policies around discounts in supermarkets, all the way through to providing appropriate labelling when people choose to eat out and eat well, all the way through to people obviously undertaking physical activity and being more aware of what a good nutritious meal looks like, a sort of part of a collective programme of work. What it also includes is an NHS digital platform, so people who aren't necessarily joining gyms or particular exercise clubs, etc., aren't their bag, then they've got an online approach as well that provides them with tips and hints, menus, all sorts of different things, so that they can obviously understand what a healthy weight is and how to achieve it in the short time frame that we obviously want to create a kind of a social movement around this. One of the other things that complements that is the cooking and growing community model. Again, so making sure that our communities understand the assets that they've got locally, that we're working with communities where obesity and overweight is a real challenge, it has been for some time, and working at a sort of a family level to make sure that people obviously get the best start in life, that they are able to understand how to grow things that obviously are suitable for cooking, make sure they've got the skills for cooking, because I think we've assumed previously that people know how to cook healthy meals and nutritious meals, and making sure that obviously that is sustainable within a community. So there's a programme of work again that helps people understand how best to make the most of the assets that they've got on their doorstep. I'll stop.
Thank you. Particularly pleased to see the cooking and the weight on the same page. That's so particularly pleasing. And certainly I've referred patients into the National Digital Weight Management Programme, which is particularly good for people for whom they're not the typical Slimming World audience. So I think it's much better for our diverse communities. It is available in different languages and different ways to access it. And I think it's really good to see that diversity of provision for our population. So really pleased to see that. Any comments or questions for Lucy?
Yeah. Sorry, Lucy, on the cooking one, is there any evidence that it works?
We only just started it.
Yeah, we tried it in Shoreside and it didn't work.
No, so we've built on some community programmes, once it's called Ground Force, but that's the old TV programme.
Anyway, don't worry.
But there's a programme of work in Corby and in Kettering that have been doing community cooking programmes, but on a much smaller scale for some time. And they've had great engagement, particularly around children who have free school meals, and they go there and they provide activities during half-term time as well. So we've got evidence in that respect, but we've never rolled it out at this scale before. So evaluation will be key over the next few months.
Yeah, now we did try, and we also tried community fresh fruit on estates and stuff. Mm-hmm. And the evidence we got from Tim Lang, Tim Lang told us that they're great for community capacity building, but don't change diet at all.
Yeah, well, so we'll have to see. So like you say, there are other benefits, because a lot of people that are attending aren't just attending for the healthy weight element.
Exactly.
They like being outside. There's a mental health benefit and a community connectivity benefit to some of these programmes as well. So hopefully it would still address some of our challenges around healthy eating, but you're right that, the benefits are much wider and shouldn't be, therefore sort of put to one side either.
And again, we're starting with wider determinants of health. This is not about health services. This is about actually so many other aspects that affect the health and well-being of our population. It's so much more than the NHS. Absolutely. So really pleased to see that. Chris.
Continuing on Naomi's comments, given that the rate of the general population has been going up over the last 30 to 40 years, despite multiple government targets and things of that nature, do you really feel that things will change? That's my first point. And my second point is, if you're not careful, you're going to have a slightly user benefit. So those who want to change will change, but those who should change will not engage.
Okay, so your first point, this is going to be a very slow burn. We talked earlier about long-term outcomes. This isn't something we're going to change overnight, and this is generational. And we've probably now had into our third generation post-war, where food availability and the cost has come down. Clearly, some of the more recent policy changes may mean that we can't afford to eat some of the things we've been eating previously, but obviously this will take some time. We've been working with schools for some time, but the problem is obviously the children don't cook the meals when they go home, which is why we've taken a much more community-based family approach. But if we can chip away at it slowly, and then there are bigger programmes run by the NHS, then hopefully we'll start to get some traction. But I do recognise it's going to be some time before we see significant change. The second point, which
Unhealthy user bias, effectively.
but you get that with everything. So this is part of the challenge, is you get that kind of self-selection bias where people who are already interested and potentially already were therefore quite conscious of how they eat and what they eat will join. We do obviously have a piece of work that looks at targeting particular communities where actually they have some of the poorer outcomes in relation to managing and maintaining a healthy weight. But again, we'll have to test how well we can engage. The other thing that we are not very good at is doing this in a culturally sensitive way. We tend to grow sort of British vegetables and fruit and assume that everybody will want to eat that and provide recipes that are very sort of traditionally English by background. And we know that some of our communities that have some of the biggest challenges around healthy weight are people who wouldn't engage in that kind of culinary activity. So again, some of the cultural sensitivity challenges I think need to be addressed in this. But obviously, if we don't try and we don't evaluate, we won't learn. So I'm glass half full on this one. And I think, again, we're hitting the communities at a point where they do recognise they need to change. I think everybody's become more health conscious over the lockdown, even if they don't feel they've had the opportunity to actively engage in changing some of the things that they would like to.
This may be a teachable moment. So thank you. But I think your scepticism is welcome, although we will do our best to overcome it. Thank you. So thank you very much, Lucy, really appreciate it. And I think public health is so important and absolutely part of our system moving forward. It's going to be really important that we continue to work on those principles and the wider community as well, so thank you. So the next item that we've got on the agenda is the governing body assurance framework. So this one is yours, Stuart. Obviously, we've got a very extensive summary at the beginning, and I'm just mindful that we will need to keep an eye on names to make sure that risks are covered, given that Lucy is one of the people who is on the front sheet. And over to you, what else would you like to tell us?
Yeah, I'll bring up highlights. So you're right, the summaries in the cover sheet, which highlights most probably three things worth noting. One, two risks have increased, and there was a theme, and there was a third risk added. So the two risks that have been increased are 3 and 8. The first one being the workforce for the Northamptonshire ITS, which has increased. 8, obviously, which we've started to discuss, is the transition of the ICB day one, originally April 1st, now July, with boundary changes, so you would expect that to. And the last one, which is the new one, G10, which is establishing the shadow form for the ICB. Anything that will entail. So that's obviously because they've changed the time frame.
Thank you.
And obviously, the relevant person will hopefully be in the room if they need to ask some detailed questions on their risk. Sure.
Indeed, absolutely. Thank you. Anybody, any questions on the assurance framework? And I do like the particular risk picked out at the front. That is extremely helpful and a lot easier to see than the very tiny script on the main thing. So much appreciated. Thank you. Anybody, any comments? Sarah?
Just one on risk number 8, which is one of the ones which has increased. We've got 2 different dates in the report, but in the body of the big table, we changed the risk to say July rather than April. So we're measuring the risk now against a July establishment. And as Stuart says, one of the reasons for the changes there is particularly the boundary change and its complexity, which we talked about under the transition item. But just to tie that together with the risk itself, it's now a July measurement.
Thank you. Okay, so thank you, everybody. So we'll move on to the next item, which is always at least 2 items from Stuart, which is always helpful. So the next one is the finance report.
So this is a report at month 9. The CCG at month 9 is 5.7 million underspent. It is still expecting 1.9 million of additional allocations to come in. That would leave us at 7.6 year to date. We are forecasting just over 3 million surplus at year end, because as the government body agreed, we will be distributing some of these funds between now and year end. So we are on track. At this moment in time, no real risks to highlight on a financial basis for this year. Next year different.
Yes, thank you. Yes, money is not our biggest issue this year. There are many other issues within our system, and unusually money is not one of them. Thank you. Any comments for Stuart?
Two quick comments really rather than questions, Stuart. But first to the in-year position, just to acknowledge, because I don't think they're so close to it, doesn't immediately jump out from the paperwork. There have been and continue to be an awful lot of moving parts, as I often describe it, from a financial maintenance point of view, and a lot of allocation change stuff and things that we can do on currently from Electric England into local systems and so on. I know you and colleagues have been working hard to appropriately make sure we maximise opportunities through all of that, but just to acknowledge from here that I think of all years from a financial arrangement, I know our finance committee will be working their way through this to make sure, and also audit, they've got their head around it appropriately, but there's a lot of stuff at movement in all of this. There's an upside there, as Joe rightly says, in year finance isn't our biggest challenge in the system by any stretch. Which links to my second point, to your sort of very brief note around underlying positioning going into next year, and we'll come back to it on the back of Sarah's item around planning guidance at our next meeting going forward with ICB arrangements. But clearly our underlying position looks very, very different as a system, and we're going to have to work very hard collectively to figure out how we reconcile that with applications into next year. That's not for today's discussion, but just wouldn't want anyone around this table to be under any illusion that the in-year position, which looks remarkably comfortable, frankly, and it is in no indicator of the kind of conversation that we need to get to around underlying position.
Thank you. Will.
Yeah, thanks, Joe, and thanks, Stuart. Apologies if this is a stupid question. Is there any risk that that any of the monies may not be carryable forward into next year? And question one, and question two is, apologies, maybe it's in the paper, I missed it. Where are we on capital as opposed to operating costs?
So, as it comes to carry forward, obviously, as Toby's correctly, we are trying to maximise for the system what we can do. Benefits we've got this year into future years. Obviously, there is audit requirements, the money is spent and not carried forward, or prepayments as part of the NHS. That does limit what the NHS can do. But what we have done is maximise what we can with system partners. So that's both our health partners and our social care partners, to make sure we're in as good a place we can be for the start of next year, knowing some of the funding we've received over the last 2 years will be removed nationally, and then we will have to adjust accordingly, and that will leave us with some challenges. Capital, yes, that's all within these numbers for revenue purposes. Going forward, it becomes very different, where the ICB is allocated capital as it is revenue, that it then agrees with partners how that's distributed. So that is part of the process we're going through now, as long as the planning round is capital as well as revenue. It's not given to individual organisations anymore, it is given to the system. Did I answer your questions?
Yeah, I think that's very helpful. Thanks, yeah.
Yeah.
Okay, thank you. So, any other comments on the finance report? Okay, thank you. So we're now going to move on to the contracting and procurement report. Over to you, Sarah. Obviously, we have read it. Tell us what we need to know.
Thanks, Joe. Just a few things to pull out in terms of key things either contained within the report or just things that have moved on since it was written. So the report outlines the arrangements for, or changes to arrangements for independent sector contracting for Q4, surge arrangements if those are required, system being supported by the elective care board to manage those if they're required, but currently they haven't yet been enacted. But the paper does outline that change to the independent sector, particularly for surge activity. It outlines the planning requirements for 22-23 in slightly more detail, and also the contractual requirements for 22-23, as they will be proposed to be changed currently. Most of those changes which are out to consultation are around performance requirements and potential changes to the standard contract required to mobilise ICBs. So there are quite a number of changes proposed in the consultation, but they're the two main areas for change in terms of the national contract. You will note from most of the tables in there that there are a significant number of underspends as briefed by Stuart as part of his report. So we've got a number of underspends across the board from a contractual point of view. The paper also references And this is one of the things that has changed. The paper references some risks to some of our independent sector partners about vaccination as a condition of deployment. Most colleagues I suspect will know that those requirements have changed, and therefore just to brief that those risks are now less/different. So that obviously was going to come in from the 3rd of February and no longer is being treated in the same way. And then from a procurement point of view, the procurement report at the end simply gives you a current overview of the pipeline of procurement, I think specific to highlight there from a risk point of view. They're the key things from the report, and happy to take questions.
Thank you. And I think it's particularly helpful to see things that are upcoming and pleased to see that the things that are not required now but will be in the future. It's really helpful to have those on the horizon. Thank you. Any questions for Sarah from a contracting and procurement point of view? You seem to have satisfied everything that people needed from that paper, so thank you. Much appreciated. So we're going to move on to the quality report. Welcome, Gabriella. It's lovely to see you. Report very much appreciated. Is there anything you would particularly like to draw our attention to?
Okay, so taking the report as read, and it is, as I think Sarah said, things have moved on since then. So to update you on Broomhill Hospital, that is now off the list of and has gone back to routine monitoring due to it being requires improvement by CQC now. So a lot of work undertaken there to get it up and running, and pleased to see that it's off the list now. Just to say that the provider has agreed to a phased admission, and they're sticking to that, and we're continuing with host commissioning meetings and quality improvement boards to ensure that they continue to improve. Another thing I would like to mention within this report is maternity. Now, we have just had terms of reference agreed for the maternity visit in March. However, that has been now superseded by NHS England, who are going to review their Ogden report within Northamptonshire, and so the CCG will be supporting NHS England to undertake that visit. I don't know if anything that you want to add to that, Ellie.
Only to say that it is a concern with the acute hospital providers and themselves to work together to make sure that we support the staff and the services. But it is one of our biggest risks in this currently.
Okay, moving on, there was within the report for both independent hospitals concern about the 52 weeks and the length of time. Just to update on the January figures, so for BMI 3 Shires, there were 0 patients on a 52-week wait, but they are now undertaking harm reviews from a 45-week wait perspective to identify any harms. And Woodland Hospital actually have 50 patients with no identified harms at the moment, and they've agreed to implement the local harms procedure process. To update on that. And just to further say that during the major incident, CCG, 15 people from the CCG were relocated to the Specialist Care Centre at 10 Furlong. For those that don't know what that is, it's a 52-bedded rehab unit that's actually registered under the council to provide nursing and rehabilitation care. And the aim of our redeployment to that unit was to increase flow and free up some of the beds. So I'm sure I'm killed if I didn't mention that piece of work that had happened. And just to finally say that Northamptonshire has been selected as one of the first areas to trial the collaborative to improve care, which is aimed at domiciliary care providers, care homes, as well as from a PCN point of view, those clinical leads that are going out into the community to provide support to care homes. And that is to look at training people in management and leadership and experiencing grassroots level problems and developing up what the solutions might be to some of those issues in the community are.
Thank you. Very much appreciated. Thank you. Any questions for Gabriella? Toby?
Yeah, two things for me and comments more than questions, Gabriella. The first, just on the maternity piece, that the risk of being a bit semantic about wording and language, but conscious we're in public session and taking notes of this. I think where we've got to on the review work was rather than a superseded, more a joint agreement with regional.
Yes, sorry.
No,
yes.
I'm sorry to pick up on the wording, but just with the session we're in, where in effect we said that, look, and the CCG team were talking with the Trust back in December about some form of review of maternity services. Alongside that, the regional team doing a routine kind of series of Ockenden kind of follow-up review exercises. And actually, Ali, I know you've been in the middle of this conversation with regional the Trust around actually let's not do two things, let's combine kind of forces and do a single exercise, cover what we need to cover and do that once for the staff as well who are feeding into it. So just for clarity to that, more of that follow, no doubt, as we go further through that work. The second point, I just wanted to, actually no, I'm going to make 3 points. I wanted to make my thanks to the quality team in particular for their heavy contribution to the secondment of staff into the work from an SCC point of view. I know the last 6, 7, 8 weeks have been really pressured across the system in all kind of settings, and all partners were asked to do anything they reasonably could to help support in terms of flow, in terms of capacity. I know that wasn't an easy ask, and at times we actually really struggled to create further capacity simply because of the workload pressures and workforce pressures. But I was really glad the CCG was able to play a role, albeit a particular role in a focused way. And I have asked Ange to put together a report coming out of that of some of the learning from that exercise, because actually what it did, of course, was put a whole group of people, Gabrielle and others, very much closer to the front line. Some of our staff would routinely be day in, day out, and I think it's helped them to identify a number of things that we, local authority partners and others around that set of facilities could do differently. My third point, and I could have raised it here or under the next item on performance, is just, we shouldn't, it'd be wrong not today to acknowledge that since we were last together in terms of board meeting cycle, etc., informal session anyway, the system has come through a tremendously pressured period in terms of Omicron, in terms of response to that. All partners, I genuinely believe, have done what they could and played it as best they could to step into supporting and working with each other. Having said that, it is undoubtedly the case that the levels of clinical risk, hence raising it here around quality, have been differential in different settings, and particularly from an acute perspective. And I'd also suggest from an EMAS and community response perspective, at times inevitably there have been levels of risk there that we've been trying to work hard to balance across the system. So I know that at times we've not all been able to do as much as we might have wanted and asked other partners to be able to step in with, but I think the collective effort and certainly the role that various people around this table have played trying to pull that together. But we're not out of the woods yet on that. Was the Omicron position might be easing and COVID numbers. If you actually look at our operating levels in terms of our overall kind of status across the system, I know I've done call over the weekend, things continue to run really hot and pressured, and that doesn't always come to life when we chunk it down into our individual service areas, which is why I wanted to make that general acknowledgement.
Absolutely. Thank you. I'm mindful that COVID is still a risk. There are also other areas of risk as well. So I think it's important that we take these as a broad area rather than look at one specific area. Gabrielle.
Hi, I just wanted to pick up on the East Midlands ambulance part of that, because the county-wide patient safety, it was agreed, EMAS attended, and it was agreed that Northamptonshire would implement the harm prevention tool to support patient safety and recognise any patient safety incidents during that time of handover. So there's a piece of work ongoing with that as well.
Thank you. Ali.
I suppose, Chair, my point is about triangulation, risk, performance and the transformation work. So there's always a connectivity. We don't always as a system work our way through that, which needs to develop further as become an ICB. But picking up on the point Toby made about the maternity reviews, if you take maternity out of this, once we have a problem area potentially, sometimes the tradition is everybody wants to do a review, national teams, local teams, we do it, internal reviews. So talking to Chief Exec of NGH Heidi, it's how do you protect your staff when that's there, because you need to help them and not review them to death when this is all happening, which is why that was the real reason why we decided to integrate the reviews to make sure that they were supported as well as it's a bit of balance, isn't it? Scrutiny and support, I think. And I think that's a slightly different point, but additionality to what Toby's saying. And I know if Heidi was in the room now, she would be saying the same thing, hence the decision. Really.
And I think when we were talking about risk, we were saying finance isn't our biggest risk. Resilience of our workforce across the system is probably our biggest risk, both the sheer numbers of staff, but also the mental and physical capacity of those staff. And so we need to be mindful of this having a positive effect on them rather than a negative effect as they continue to care for the population. So I think that is entirely reasonable given the situation we're in. Thank you. Any other comments on the equality report? Okay, so if we move on to the performance report, Sarah, what do we need to know?
Thank you. A number of the things you need to know, I think, have already been covered as part of the item beforehand. But I was going to highlight a couple of things. One, in terms of, obviously, Toby's talked about system pressures, major incident, etc. That has had an impact across the board from a performance point of view. The performance in this report isn't as we would want it to be for our patients, for our population. It is the case that we are running ahead of, in a positive way, most of the England average performance. However, we are running behind national target as well. I think that nuance, it feels important for us as a population. I think the other thing I just wanted to cover was particularly elective weights. So our NHS provider in county position for elective weights is a relatively positive one. No 104-week waits within NHS in county providers, but we do have some challenges with our independent sector providers in county and our out of county providers. So in terms of waiting times for our population rather than for our NHS providers, some challenges still there for us, which we're working through as part of an integrated approach to the planning round, as I spoke about under the previous item. I wasn't going to dive down into any of the performance specifics unless colleagues have questions in that respect, but really, therefore, just to outline the challenges they are as have been described under most of the other items.
Thank you. No, I mean, I think this is just as a personal comment for knowing it open for other questions. It is a good report. It looks very much like a CCG report. And I think one of the things that I'm looking forward to as time goes on is to make it look more like an ICB report, because I think a lot of those areas are still areas that the ICB will be interested in. It's how we organise and arrange them, not necessarily the data. And it does look like CCG as we're now mindful of the system.
And I think probably just to add to that, so there is a working group working on what performance reporting needs to look like for our new arrangements. Acknowledging the performance in this report is therefore, I'm going to say, old in terms of it's not up to date, it's not live performance. We're still working through the challenges in terms of live performance and access to out of county and independent sector provider information on a live basis. What you have in this report is a whole sector validated position for the county, which is why it's December's data largely. But we are working through as a working group with all providers and commissioners represented how we get through some of those problems and make this reporting look different. It's a work in progress, and there are both some analytical capacity challenges and some information flow challenges. But I would hope over the course of the next sort of 6 months or so, this report does start to look quite significantly different.
Not a criticism of this, but more an aspiration moving forwards. Thank you. Andrew.
Yeah, again, it's not a criticism, it's more of a question in terms of, notwithstanding COVID and all the pressures, you know, very hot systems in the winter is a common thing. Are you confident, Sarah, that the channels exist to pick up the lessons that we've learnt this year to actually not be in this position next year?
I think some channels do exist, Andrew. So we're doing and have done, or are in the process of doing, sorry, more accurately, a system review of the activity that occurred during the major incident declaration, what we can learn from that. We've got some useful lessons learned framework pieces from COVID as well. And also, I think, particularly in the collaborative spaces, working through with ICANN in particular, what some of those lessons might look like as well. Whether or not we've yet got to the stage where we've coherently drawn them all into one place as part of planning for next year, I think we've probably still a bit of work to do on that. But I'm confident we've got the people in the right places having the right conversations. I think there is a coordination piece still to do, however.
Thank you. Ali.
couple of points from me. First point is the lessons learned piece. I think we do a lesson learned deep dive, but I don't think we embed our lessons learned into the system in the way that we could, and the triangulation piece. So I think that is something that as a system we're not good at, and as organisations are working together. Second point was going back to maternity and the triangulation, because the performance report for maternity is the greenest in the pack. Yet we've just had a conversation about problems within maternity. So it's the lens that you look at each of the reports on. Again, it goes back to the triangulation.
Thank you. Any other comments or questions on the performance report? Okay, thank you. So I think, as I say, quality and performance both equally important and very much interrelated to each other. So thank you for those items. So we now have Anna, who has joined us to talk about the vaccination programme. Obviously continues to be strong. Thank you for all of the data. There is a huge quantity of data. So for those of us who like data, appreciate it. Tell us what we particularly need to know.
Okay, sure. So since I've seen you last, the work has continued in earnest, but it's changing shape, I think it would be fair to say. So we're looking much now towards what the future looks like, really trying to reach some of the hard to reach population and those reluctant to come forward. So in that spirit, we continue with the programme. We have vaccinated, we've given 1.5 million jabs now across the county, just shy of. So still making progress there, but it's getting more difficult. We remain above the regional average across all the booster cohorts at the moment, so keep progressing well. But to put it in some context, in the big push before Christmas, one very special week, we vaccinated 77,000 people in the county. Last week, we did about 4,500, 5,000. So that just gives you an understanding of some of the scale now in terms of where we're going. Key focus is increasing vaccination in pregnancy at the moment, because that's probably the only indicator where we are under the regional average. So it's thinking about what we can do with our maternity services. So last week, we embedded teams within Rockingham Wing and the Barrett at NGH and KGH, and has been massively successful, if I'm really honest, but we're doing absolutely everything to try to increase the numbers. So we did about 22 in KGH and about 6 in NGH last week. So we just keep innovating and adapting to try to absolutely get people to come forward. Expanding the programme with increasing our mobile vaccination service. So we've got one of our community pharmacies that's been leading a service in partnership with Public Health, popping up, looking at that MSOA data and making sure we're putting provision where it absolutely needs to be. Maximising grab a jab and walk-ins, that's just very commonplace now, that combination of being able to book and being able to walk in. Continue community engagement, again with public health colleagues to support that, really right down to street level and marrying the services up with the need. 5 to 11s we've started to vaccinate, so those hard to reach, not hard to reach, but the high risk children. Uptake's been very, very low, so we've got a cohort of about 3,000 children. And we've had our uptakes about 1.5% of those at the minute. So we all wondered how it was going to go with the young ones, but we're not out of kilter. We just need to do some work and work differently to really engage with those young people and their families. It's very different motivations and dynamics at play there, really. But that continues to be a big focus with a view to healthy children probably from March, April time. Another big focus has been our move to business as usual and what that looks like going forward, that I'll touch on a little more in a minute. There's a slide there just around loads of the comms activity. We just continue to push all the comms, social media, paid for media. We've had TV, we've had radio, we had the Prime Minister at the beginning of January, so that was much excitement there, would be fair to say. We've included all the latest booster statistics that speak for themselves. I've just added there about the 5 to 11 at just 1.5%, say above regional average with our booster coverage. The pregnancy data is there, which just demonstrates what I've described really in terms of us being a bit behind, but working with the heads of midwifery to progress that. So our key risks and issues. So vaccine management, wastage, ordering, returns consumes a huge part of the activity at the moment and my life, quite frankly. And that is as a consequence of a big push of vaccine before Christmas, when we had all the boosters brought forward and then an excess of stock in the system. We then stopped getting supplies because we need to use the expired vaccine up, and that's caused some big logistical challenges. So at a site level and a programme level, but we do seem to be getting through some of those now. Workforce retention for the future is going to be a challenge too, because it's very unpredictable. And that's on a kind of delivery level, but also from a programme perspective, because we don't know what the programme is going to look like. There's a planning paper that's due out in the next couple of days, a national paper that we'll be able to respond to. It will be set out in 3 stages. So it will be from April to August, and then from August to December, which will align much more to the flu programme. And then what does the long-term structure of the programme really need to look like? We still haven't got a true indication of whether we'll be doing annual boosters for everybody, whether it will be 50 pluses. So that should be much clearer by the end of the week. We continue to battle with public apathy and disengagement now, particularly with the Omicron variant having a lesser impact in terms of hospital admissions and death, which is taking some of the wind out of it a little. So we expect volumes to be low for the next couple of months until we get to a point where we're doing more boosters and geeing back up again. We're also looking at demand going forward for the 5 to 11s, because we've got about 9-10 providers supporting the at-risk children, but when that balloons out to all children, we've got a much bigger cohort, so we'll probably extend that out to community pharmacies and so on too, to support them. I think, so just in terms of the business as usual proposal, that's going to Chief Execs tomorrow, and we'll take any feedback from that and then take that forward. It's a mixture of really looking at what posts we need to establish on a permanent basis now, because this programme isn't going anywhere, but then also thinking about what provision looks like. So LVSs, our primary care services, have absolutely been the backbone of the vaccination programme, delivering about 60% of vaccinations. In the future, that may well change, because we know primary care have had to prioritise vaccination above other work. So what does the long-term future look like? Community pharmacy has really stepped up. We started with 4 pharmacies. We're up to, 22, 23 pharmacies now. We've talked to about the future of the vaccination centre over the road, and it'll be recommended we hang on to that until March 23 to build some resilience in, essentially, if we do get we get a new variant or we get another big booster programme or something, but look to how we might utilise the space more effectively. So that's kind of the headlines really. Like you say, there's loads of data for a good data fan, but I'm happy to take any questions if anybody's delved into the detail of it.
And I think I will probably speak for all of us. I want to say thank you to everybody who's been involved with it so far, and obviously moving forwards as well. This has been a huge amount of work, and really, really big thank you to everybody. I can see Andrew on the screen has a comment or a question. Andrew.
Well, it was I think it's a fantastic job. But what struck me when reading the report was that some of that amazing work gets lost in the statistics and all these sort of comparison charts. And I just wondered whether there might be a more emotive way of looking at it, and which would be emotive in terms of encouraging take up, but also rewarding for staff. It's just to look at a simple metric of how many lives have been saved. Because I think it just tells the story, and it almost didn't come out from all the great figures that are in there, but people have been saved because of this work.
Yeah, indeed, and I think we've often talked about some of the public health information, Lucy, that you've had, where we've been able to take ICNARC data, for example, which is the critical care data, and look at the numbers or the proportion of people in critical care or who have died who have or haven't been vaccinated or have been boosted. And I think that's some really powerful information when we engage with the public, and we have done some of that. I think there is a level of nervousness sometimes around doing that on a very, very local level, because you quickly get into small numbers, which can be difficult. But I do agree that's where a lot of the rich information is. I think though that's more challenging now with Omicron and some of the kind of perception stuff around that, but can certainly take that back with Lucy and with the comms team and go, is there any of that information we can use more effectively to persuade the reluctant, essentially?
Philip.
Yeah, I think our practice is probably pretty typical of what's going on, in that we're a practice that provides PCN vaccinations. And we've done the vaccinations at weekends, and we've got 3 clinics planned. There's 100 patients roundabout in the next clinic because there was a delay in vaccine delivery, as you mentioned. And then the 2 clinics after that have got 20 patients in each of them booked at the moment. And when we get supplies of vaccine which come in batches of 100. And as you've mentioned, we're very concerned about the potential wastage of vaccine. You know, a huge percentage of vaccine is going to be potentially wasted. And people are beginning to ask, certainly from a clinical point of view, what do we plan for in the future? And, you know, what plans have we got in place for ongoing service delivery for those reduced number of patients who still need vaccination?
So I think, first of all, it's understanding, is there a reduced number? Because we don't truly know yet. And so we need to wait for the JCVI guidance to come out, hopefully very soon, so we can plan for exactly that. The modelling that we've done and workshops we've had, what we've heard from our PCN sites is there's a willingness to continue, but there's also opportunity there in terms of actually co-administration with flu as it falls more into line with flu, which we haven't really been able to do because everyone's been due at the wrong time and so on. So that might make it easier and more effective for PCN sites to continue with, to roll in with that. But with community pharmacy very much as that buffer and as that backup. We've also had conversations with regional and with national around the batch sizes, because it is a huge problem, and it was a huge problem when we were receiving boxes of 1170 vaccines before Christmas, and then you can't move them and you're very limited. So we're down to 90s again, which is still a lot for some sites, but that's as small as we get it right now. Ideally, we'd love to see a place where it's single packaged, like the flu vaccine, and you can buy it, you know, you can order it in much smaller batches, but we're a ways off that. And I think everyone, I know that everyone is raising exactly the same issue around vaccine. What we're saying to sites at the moment, and I've had this very conversation this morning, is we appreciate your numbers are low, but bring your 90 in, request your 90, and then we can move the surplus elsewhere to avoid the waste. 90s haven't been such an issue, to be honest, and I think we can manage that and keep the waste to an absolute minimum. It's the big batches that were a problem. So I like to think we're working, and I know Dina at your practice, I know everybody at every practice, we're working so closely with them to try to reduce that waste, but we also have to work within some really strict mutual aid and pharmaceutical policies and processes around what we can move and why we can move it, which can be really restricting as well. So I hear and feel and echo some of the challenges, and we're voicing that upwards as well.
Okay, and just to comment for myself, I mean, I'm mindful of the conversation we had before about health inequalities, and obviously those who are willing to be vaccinated have often come forward, but we are in the more difficult communities and particular groups of people who very much would benefit from vaccination and are not willing or not coming forwards. And it is one of those inequalities that may move forward, obviously not a protected characteristic, but in danger of becoming so, that those unvaccinated are at significant risk moving forwards. And despite what might be said elsewhere, COVID has not gone away yet. So I just really wanted to put that on record. It is still here at the moment and still a risk, particularly for some parts of our population. Thank you. So thank you very much, Anna, much appreciated. So we're going to move on to item 19, which is our Safeguarding Children Annual Report. And we have another appearance by Gabriella. This is an even longer report. This one's very, very detailed with some lovely quotes. Is there anything you'd particularly like to bring our attention to?
Yes, it is long and detailed, I'll agree. So and it's not one that I've written myself, so I did ask our safeguarding colleagues what 3 things they would like me to pick out of this report, given that it has so much information in there. So forgive me reading, but I will tell you what those 3 points are. They would like to highlight the excellent work provided with regard to the emotional well-being for carers, children and young people and professionals during the pandemic and currently, to include the Voice of the Child slide. So the Voice of the Child slide, I think, is 307, page 307, and that gives their individual reflections of the service. So they would like that to be brought to the fore. To acknowledge that there have been challenges with review health assessments, but funding has been approved and this is now being addressed. And also the initial health assessments that raised that they were a regional and national issue in terms of timeliness. Some of this has been down to COVID and workforce issues, given all that we know about that at the moment. But they're currently working very closely with partners to address that and the timeliness of those reviews.
Thank you. Any questions or comments on the Looked After Children report? Maybe?
Yeah. So I agree that the report reflects the good working between the council and the CCG. There's been a lot in particular, not exclusively, but through the sort of partnership arrangements. And it is a very detailed report and it is very comprehensive what it goes through. And I guess my comment is probably less about the intention and purpose of the annual report and more about what we do going forwards, because it's very long on analysis. It's very light on, so what are the residual things that we need to do something differently about to support both the children and also the sort of families that are involved and connected and impacted on by what is contained within the report. So I was struggling at points to be able to come away from reading with a clear sense in my head almost of your 3 points. So what are the 3 big things we're going to do next? And the report talks in the next steps about where do we need to go next. So it's the very last point. It doesn't give me any kind of prompt or feed or insight to say those folk who are close to this think the things we need to do next are this, this and this. So my apologies if I missed it within the materials here. Appreciate it's not your personal report in terms of what's been authored. My comment was more both partly to take back to the team and partly it links Ali into the collaborative kind of discussion that I know we've got on Thursday on the Children and Young People's Collaborative, because I think this kind of material ought to be one of the key feeds into the Children and People's Collaborative, which is emerging and which for others to benefit is less progressed in terms of its case for change work than the mental health and the elective ones we looked at earlier on. And I think the key issues and things coming out of this, so my answer, I suppose, Gabriella, to try and frame this as a question will be to ask them to be able to identify the 3, 4, 5 key things that they would like the system to work on next in order to better support and address some of the issues that fall out of this from a numbers perspective, because the scale, there's sort of 1,100 numbers that wasn't it, the continued high levels of cases in Northamptonshire compared to surrounding areas. I genuinely still don't understand why we were at quite that level and what we need to do next is different here. So I guess it's a forward look as much, Chair, as much as a comment on the report and what's contained. Thanks.
Yeah, and Ali and I have had a very brief discussion about linking up a bit more collaboratively to get some of that work addressed as well.
Thank you. Chris and then Ali.
And it's probably more continuation to Toby's comment, to be honest. Given there's 1,100 or so children and you've only just started collecting that other health data, you commented on asthma being equivalent to national levels, there's only 2 children who are apparently overweight. out of 1,100.
Doesn't really reflect what
Doesn't
Lucy was
reflect
saying, does it?
precisely my point. So I appreciate it's early data, but clearly a LAC child usually has an annual review by a clinician and they usually check their weight. So by inference, going on Toby's comment, surely the aspiration should be to coordinate with what the public health aspects would be for the system. And this is a vulnerable group, and surely they should have the same. And dare I say, can I suggest mental health of this individuals is prioritised above anything else, particularly later ages? Personal, I will bow to people with more knowledge about that in due course.
Lucy, did you want to comment on that?
I think if people start to use the outcome framework, you'll find that there's a lot of mental health outcomes that are prioritised for children and young people in particular. So yeah, absolutely.
It's all putting together. It's good.
It is. It's starting to come together.
Ali.
So from a collaborative perspective, this is one of the problems that has been articulated as being, well, we need to resolve this collectively. The other point I'd make, and I will feed this back to the safeguarding team, we've had this problem for 9-10 months, the review of the health assessment, and we've still got a problem. So I'm not sure why, but I think we need to acknowledge that, because that's the root cause of what we're describing here, and that's why the children end up where they are potentially. So it goes back to that triangulation of safeguarding the quality and then what's happening with the collaboratives again. So it's more of a comment, Chair.
Yeah, thank you. Naomi.
Yeah, I mean, it's a different, it sort of picks up on what Toby was saying. What concerns me is that how do these children wind up in care? Yes. And what are we doing as earlier intervention and prevention? Yeah. And I just don't see that anywhere. I see most of the concentration on the work that we're doing on children is at very high end, very complex needs, and isn't looking at the child population. Yes. And it's interesting, Lucy, in your report that there were like, of the top 20, 15 related to children, which does tell us something. And yeah, so it's not, it is very, very important that we do the best for children in care. But in my view, it's even more important that we have fewer children who need to be in care. And I just don't see that happening. I mean, it probably is somewhere, but I don't see it as part of the story. And it is extraordinarily important.
And I think particularly important on the background that we have always been an outlier, or certainly for as long as I've worked in the county, we've been an outlier, and much than we do need to care for these children, it would be better if they didn't need to be looked after.
I mean, outlier is being polite. We were failed children's services. You know, it was taken away from local government. And I think that really, you know, I mean, it's really, really worrying.
Philip.
Well, it's following on from your point, really. And we have great concerns about the closure of the children's centres a number of years ago, right across the county. And I wonder, Lucy, if that was part of the problem. I know my MP is leading a working party in the House of Commons into this very issue, and she is passionate about early years support and the preventive benefit it has throughout childhood and adolescence and into adult life. Which we as a county could probably improve on. But I'd be interested to know if the closure of the children's centres has led to any measurable increase in these issues.
So I don't think there's ever been any research done on the correlation of outcomes versus whatever our policy or approach may be at any one time, but it is a very good question. I think we do have a view on what's been successful and what's not. I think there's certainly a desire to, and obviously it aligns with the policy, central government policy narrative around bringing services closer to our communities. But from an ICP perspective, the Children and Young People's Programme of Work absolutely want to look at that kind of multidisciplinary hub model within communities. Call them what you like, but they sound very much like Full Start Centres and various.
I won't call them that.
And I know adult social care have already started to get that sort of MDT community hub model going, and I think there's a lot we can learn from the ICAM programme and the adult social care work that's happened. I think the other thing, just to remind people of, is obviously we've got a section 75 between the CCG and public health at the moment that we continue to put more and more contracts in with a strategic ambition to start to join services up better for children and young people and their families. I don't think that we're where we need to be with that, if I'm honest, and there's still some gaps in services, particularly where safeguarding comes in, where people don't quite meet a children's safeguarding threshold, but they need more than the Public Health Commissioned universal services. So there is a recognition of some of the challenges still in the system, an ambition to bring things much closer to communities and the families that obviously we need to support. But we haven't quite got there yet, but it'll be interesting to see how the Children and Young People's Collaborative progresses.
Thank you. Will.
Yeah, thanks, Joe. And I thank you for this paper. I thought it was a really interesting paper and a really interesting and important subject too. And I was, in my mind, I was thinking about addressing my comments using a sort of pipeline model. You know, I was thinking what goes into the pipe and what comes out. But the discussion that you've just had around the board table on the input side, I thought was absolutely fine and spot on, and I won't therefore reiterate any of that, but I support the discussion. On the output, so I'm going to just focus on the output side, and I'm thinking here wider determinants of health, I suppose, really, and I'm thinking something very specific here that I wonder if we could become some, you know, have we got an opportunity here to be an exemplar, a positive exemplar? So we've got, I mean, obviously, ideally, the pipeline would be empty in an ideal world, and it's not, and realistically, it's not going to be in the foreseeable future, of course. But I'm reflecting on the fact that, you know, in the general population, knocking on 50% of kids go on to higher education. You go to university, you know, 48% or whatever it is at the moment. And for looked after children, my memory is, I haven't looked this up recently, you know, specifically for this comment here, but my memory is that it's less than 4% of looked after children go on into higher education, and of course that then plays into the wider determinants of health and generational impacts and all the stuff that you guys know about. And I'm just wondering if is there an opportunity to work with the university in introducing perhaps the older age cohorts, maybe, you know, I don't know whether it's 14, 15 years onwards. But to work in some partnering way with the university, introduce them to university colleagues, do some buddying, show them that this world is accessible to them, and therefore create the aspirational drive that would help them for the rest of their lives if they were able to engage positively. So I realise I might be being, you know, too optimistic, you know, you could say I'm being too aspirational, maybe even thinking, you know, like, you know, this would be easy. Actually, I'm sure it wouldn't be easy. But I wonder if there's some positive wins we could have there for kids that are in the system and they're going to be in the system. But when they transformation to adulthood could be so much better for at least some of them if we worked collegiately with our university colleagues. I hope I explained that, Joe, in sort of semi-cogent terms, and it made some sense.
Thank you. I think Lucy wants to respond to that one.
And I'm sure others will want to contribute as well, but Naomi and I were having a conversation earlier about anchor institutions. And it's a programme of work that locally I think we need to develop more, but it absolutely does that. It looks at the power of the NHS and other public services as employers, as educators, as local commissioners and providers, and starts to sort of collectively utilise the power that we have to be able to create opportunities financially, from a skills and education perspective, you know, the use of our community buildings and assets to improve outcomes for everybody, but certainly with a focus on addressing inequalities. So providing exactly what you're talking about, you know, opportunities for people who otherwise, because of their circumstances, may be disadvantaged in achieving their full potential. So it is something that's on our radar, something I think you're right, Will, we haven't done enough about. But certainly something that we as a collective need to be very much more actively thinking about. And Naomi and I talked about how we might be able to start to take that forward. So it's a really good suggestion and just the kind of thing that we were alluding to this morning.
Thank you. Very much appreciate everybody's comments, particularly about this population, but I think the wider issues around the edges of this topic are equally important. So thank you very much for bringing this report. So last and definitely not least, we have Julie with the primary care report, which is always at the end. Thank you for giving us this report. Obviously, we have read it. Tell us what we need to know.
Thank you, Chair. And this is a comparatively short report compared to many of the others, but I'll just draw out a few points if I may. Anna's covered the update on the mass vaccinations, and I think we're very grateful to our GP practices for everything that they've done around the mass vaccination and the booster programme. And the primary care team continues to support our practices and the LVSs as them being a fundamental part of the collective effort, as we know. General practice continues to see high levels of activity and appointments, and in fact there's been a 15% increase on 2019. It's difficult to do year-on-year comparison because we're talking about the end of last year. I've only got data until the end of December, but it's difficult to compare it with the year before because obviously that was the COVID year, although I know last year was too, but you know, the December 2020, it was rather difficult. But going back to the 2019, there is an increase of 15% activity. And therefore, what we're seeing is there is a risk to the retention of workforce, and we're seeing people that are reducing the number of workforce within general practice, which is unfortunate. And we are doing some work with general practice around recruitment and retention. Something that's new and quite innovative, I think, and actually is increasingly welcome with the assistance of this. So the Community Health Partnership and the National Association of Primary Care, together with NHSEI, have developed a strategy development toolkit for our PCNs. We started with a strategy toolkit at the beginning and a maturity matrix when PCNs first came into existence, which we did use locally. This toolkit now takes us just a bit further and a bit further on, which is really helpful, but also it helps because there's some assistance around it. So the community health partnerships will employ a clinical planner to work with our clinical directors, and that will be to help develop within the PCN a high-level clinical strategy. And based on that and following that, the development of that clinical strategy, they will also employ an estates planner that will then work with them on assisting current estate, on assessing current estate and any evidence that might be available to be able to demonstrate that they may need additional room or additional estates development. So I'm looking forward to the outcomes and the outputs from that, because it will really help to to support the primary care estates strategy, which, as we know, it's not there yet. So I think this work will be incredibly helpful towards that, especially considering it's being done at such a low, I would say a low level, but a detailed level at a PCN level, which I think is incredibly helpful. just to say about the medicines management team supporting general practice, about reducing our carbon footprint as a county. So because we have changed patients to dry powder inhalers and reduced the number of metered dose inhalers by 2,000, we have reduced our carbon footprint by approximately 350,000 miles of car journeys per month, which I thought was a fantastic statistic, if I'm honest. And well done everybody that has been that's been involved in that. And just a couple of things that have happened since the writing of the report, if I may, and that is the fact that we have now completed our comprehensive local commission services review, and communication will be, so this was all approved through the PCCC, and communication will be out either today or tomorrow to general practice. We've included the LMC all the way along the way, and so they are supportive of the approach that we are taking, which actually will demonstratively improve access and reduce the key inequalities agenda, which is what we were trying to do from the concept of the redesign of these services, which has now been developed and will be offered. And I'm hoping with a fair wind, we will be in a position to commission these services differently from general practice from the 1st of April. We've also included practice managers in our engagement, so it all seems to be going very well. So the final thing from me, Joe, is that we will need to refresh the primary care strategy in light of the development of the ICS and the collaboratives. I think that will be very important. It will be led through the PCCC in the first instance, and then we will share that obviously with key stakeholders for their input and feedback. And that's me. And if there are any questions, I'm more than happy to answer them. Thank you.
Thank you. Any questions or comments for Julie? Debbie.
Just a quick comment, Julie. It doesn't need a response, but just to know your last point there about refreshing strategies. The other key thing to take into account in doing that is the emerging work that's coming through nationally at the moment around the review, the fuller review in terms of primary care and future models of. And I know some people around the table have been in place. I think Naomi, you were on a briefing session with regional colleagues last week. I've been involved in the stakeholder group into some of that. And I think we could do with starting to get some of the emerging thinking that's coming through that shared locally through localities with GP leads and others as well, because I think there's some positive thinking there that's coming through nationally around future models and role of general practice and connections into lots of the kind of wider community, total care infrastructure and so on as well. And I think that'll be a pretty key piece for NHS England that will come through over the next couple of months and really just reinforce, I think, Julie, your point about actually that the time is right now for us to do some work around refreshing all of that locally. Thanks, Joe.
Thank you. Any other comments or questions? Okay, thank you, Julie. So I'm just going to sum up with a few key messages. I'm going to say thank you to Lucy again, because I don't think you can say it too many times. Thank you, Lucy. We will miss you, and thank you for all your hard work and for your leadership, particularly with your team at a difficult time. So it will be a sad thing to say goodbye to you, and we very much enjoyed having you as part of our governing body, so thank you. As far as reflections on the meeting are concerned, I've got four main reflections. I welcome the outcomes framework and our aims to focus on what makes the most meaningful changes for our population. I note the progress work by the ICS workstreams, particularly mental health and elective. I'm mindful that the people are waiting and are experiencing harm and distress while we continue to do this work. I'm aware that although we are expecting a financial surplus this year, that we will still need to be mindful for the coming year, 22-23, and to thank everybody involved in the Looked After Children report, and look forward to incorporating the comments that we've made into our improvements around the children and young people's work within the county. So this part of the meeting is closed. If we could stop the recording, please.